then you can see the curve plummet. But at 1 stage, you can see the patient who achieve unpredictable response, the lines almost flat, meaning that the chance of recurrence is almost minimal. So that's what we try to achieve for the patient with neoadjuvant DYO. When you put all the study together, at the analysis, as summarized by Serene in 2024 in Dharma Oncology, there is actually has a ratio of 5 times 5 more chance of having a CDR with the chemo-IO as a neoadjuvant therapy. Today, I'm going to talk about neoadjuvant therapy in lung cancer. Just for the interest, how many of you feel lung cancer? If you raise your hand, please. I got a few hands. That's excellent. How many of you have lung cancer if you raise your hand? I'm glad there's no hand that I can see. So why do I talk about neoadjuvant therapy apart from the fact that Charlie wanted me to talk about it? This is my disclosure. I'm a board director of this company. So what is a kind of effect of neoadjuvant therapy? I think this is that we want neoadjuvant therapy such that we can improve overall survival. However, I can tell you most of the studies cannot do that because it's too long. And a lot of studies do not pay that long to get the result out. So we have to get something in the middle, try to understand whether it's working or not. If I can get this up. So one is to improve the resectability. The surgeon would be happy about that. Second, if we take out the pathology, we achieve something called complete pathological response or major pathological response, CPR or MPR, and we say something because that is associated with the improvement in overall survival. And then last but not least, if you wait long enough, you may be able to capture the event-free survival, which is like the progression-free survival. So today's talk, I'm just to focus on these blue boxes in whether this trial is going to achieve something meaningful for the patient. Divided into two areas, as I mentioned, there is the patient without the driver amputee and with the driver amputee. The management is completely different. Allow me to start with the driver amputee positive without the driver amputee patient. So this is the simple paradigm. Patients seen by the surgeon, especially in Hong Kong, immediate surgery, and then they have a choice of chemo and the immunotherapy for 1 year. Free study. I'm 110, Keynote 090, PR31, and one additional from ASCO this year. Or you can give chemo before the surgery. There's only one chemo-IO before surgery. That's a checkpoint 816. Or you can give chemo-IO and then give IO for 1 year. That's 4 other studies. So I won't bore you with much, but you can see that there are actually 2 groups. That the chemo and IO 3 to 4 cycles before the surgery. What benefit do they bring? These are the results of the major study, 816, Neoadjuvant, and 671. The simple fact is that I'm improving the design, but this is the result. You can see that the P-star rate is around 20%. Now, not a bad thing. 1 out of 5 patients, you got chemo-IO when you do surgery. We can't see the cancer cell anymore. Now, that is something nice. I will tell you a little bit more why it is nice in a moment. But together with that, there is actually so-called event-free survival benefit. As you can see, the separation of the Kaplan-Meier survival curve, that there is higher chance to be disease-free with this use of the chemo-IO adjuvant setting. Now, a little bit touch on what NPR and CPR is. Now, it's actually a very particular process. IASLC had defined the process for the pathologist they have to follow. 4 centimeter tumor, you have to cut 4 cuts. And each line examined looking for the percentage of viable cell. And the total summation divided by 4 or 5 will be the so-called percentage of survival cell. CPR meaning that you do not have any cancer cell whatsoever in any of the sites. So with that, this is what we see in CheckMate 816. A good significant proportion, 20%, get this complete pathological response. And then there is another proportion that got 90% or more together with 100% that we call it a major pathological response. So those are determined by the terminology need. But then you can see this is the curve plummet. At 816, you can see the patient who achieve complete pathological response, the line is almost flat, meaning that the chance of recurrence is almost minimum. So that's what we try to achieve for the patient with the neoadjuvant DYO. When you put all the studies together, At the analysis, as summarized by Sorin in 2034 in Dharma Oncology, there is actually has a ratio of 5 times 5 more chance of having a CDR with the chemo IO as a neoadjuvant therapy. And the major pathological response also be worthwhile is about 3.4 times. So that is actually well defined with meta-analysis. But then does it really carry on to event-free survival? Answer is also yes. Hazard ratio is 2.59, statistically significant. So those two benefits are proven with the use of neoadjuvant chemo IO. And what about overall survival? There is some survival benefit, hazard ratio 0.65. And so this is an early data, relatively convincing, but we need long-term data, which just come out last year. That made A16 the 5 years survival data, 65% versus 55%, meaning that at the end of 5 years, there are 10% chance the patient is still alive. This is something worthwhile to the patient, and the patient must know the potential benefit in this regard. So I think that defined that very well. But then still question that we have to ask. If the patient not complete pathological response, do we have to give more adjuvant IO in the adjuvant setting after the surgery? Well, and then the relevant question is also is a PD-L1 expression relevant to the situation? So those are the kind of questions we need to ask to select the patient. Now, chemo IO is not expensive, but it's not cheap either. So for patient to go through that, we have to make it worthwhile. So first question is a PD-L1 status. This is something we examine on the tumor every time when we have the lung cancer biopsy. And you can see that the patient with high PD-L1 status is actually correlated well with the event-free survival. But then for the patient with low PD-L1, that is a marginal benefit. So in other words, we definitely should offer if the patient PD-L1 over 1%, but available if it's less than 1%. But overall survival, however, for the last 1% is not statistically significant. So that remains a little bit of debate, and also support from the 816 study. You can see that PD-L1 over 1% significant, 78 versus 58%. But on the other hand, the difference at 5 years is minimal if the patient is less than PD-L1 1%. So I think it is the standard now we offer the chemo IO as a neoadjuvant therapy for patient that is over 1% in PD-L1 status. We need more therapy afterward. It's debatable. We look at the Q671 study. There seems to be some benefit, but there is a selection bias with this database because the patients who get adjuvant chemotherapy are usually in better patients. So of course, the survival is better. So with the selection bias, we cannot completely say it. The only one thing we can do is compare CheckMate-770 versus the CheckMate-816 without the adjuvant therapy, and there seems to be some benefit. So at this moment, I think it remains a little bit debatable whether we should take adjuvant chemotherapy if we can already achieve the CR. Or can we use MDT? I mean, meaning that before the surgery, the people get together to discuss whether we should give chemo or not. In Hong Kong, also in China, but probably better in Europe, is that patient was sit by the surgeon, and the surgeon in reaction, yes, I need to cut it out because I can't cut it out. Yes, I'm sorry to the surgeon among the blade. I see one surgeon right there. But will you talk to the oncologist first to say, would it be worthwhile to get a few cycle chemo IO before your surgery? Now, that may or may not happen. That's why we need MDT. So at Prince of Wales Hospital, at all stage 3 disease, we have the whole MDT. This is actually one study from Europe looking at the role of MDT in stage 2B and 3, which is a slightly more advanced early stage disease. Now, I just want to put this forward and just say that with the MDT, basically there is a higher chance of conversion from unresectable to resectable with the opinion of neoadjuvant chemo IO. As a result, there are actually benefit, also patient. So it's increased the number of patients who converted from 56 unresectable to 72 become resectable at the end. I will just jump over it. So I think right now it's already a world standard to give neoadjuvant chemo IO, and it's highly encouraged that MTT need to be carried out before the decision of the management of the lung cancer patient at stage 2 and stage 3. All right, with that, I'm going to touch on EGFR And ALK, sorry that I had to keep on time, and also the rush back to Hong Kong for another conference, the ASMO-ACT. So EGFR. In the early link-term neoadjuvant EGFR, meaning that to give TKI before surgery, is used to be very scanty data. But this table, you can see small sample size, some benefit, not a real standard setting. So we cannot make a decision based on that. Like this study from Korea, which is a nice study, demonstrating that the patient actually had responded. However, it doesn't really do too much in the long-term outcome. So they also looked into the resectability, that they were able to increase the resection rate for the patient with stage 2 and 3B. Now, but then the key study actually is come on to let me just give this one, the Neoadjuvant study. Now, Neoadjuvant is a major study, worldwide randomized phase 3 study. The patient with a stage 1B to 3 randomized to either have chemo with osimertinib or osimertinib or no treatment. And then as a result, that is the key of the factor is to compare this to right now, is the whether it make a difference if you give a new adjuvant osimertinib to this patient. So you can see that if you're looking at PT, the so-called major pathological response, there's slight improvement, 20-some% versus like less than 5%. But look at the PCR, which they did not show on the curve. It's only 4%, 9%, and 0%. Meaning that the neoadjuvant EGFR TKI, unlike the neoadjuvant chemo IO, is not able to achieve a complete pathological response. So with no pathological response, we may not actually be able to imply there's a survival benefit. So what did the study tell us? Well, one thing they do is that they were able to cause a tumor to shrink. 90% of patients had the tumor shrinkage. What does it resulted into? Well, it resulted into the resection rate of downstaging. About 53% of the patients will be downstage, meaning that they may clear off the disease in the lymph node. They may shrink the cancer from a T2 tumor to a T1 tumor. So by downstaging, it will make it a bit easier or more favorable for the surgeon. But in terms of the interim event-free survival, you can see that it's very immature. And with that, there's actually minimal benefit in that regard. So at this moment, neoadjuvant EGFR TKI is questionable unless your objective is to downstage a patient for ease of the surgery. Now, ALK. ALK is actually more dramatic. I just released the 7-year ALK data, but target therapy is actually quite effective. There's one smaller study called the Logical study, which is actually ALK-positive, put on a second generation alectinib, and then look into their so-called pathological response. It's quite interesting. They actually achieve a higher MPR rate of 60% and complete pathological response PCR rate of 25%. Small study, but when this first come out, kind of excited, saying maybe we're able to achieve better outcome. Of course, ALK is only 5% of lung cancer. Early stage ALK-positive lung cancer even less common. So this is small size, but it's a bit representative that it may induce the complete pathological response. And only in ASCO, just 2 weeks ago in Chicago, China had produced a study called the Lorraine study. This time, instead of a second-generation drug, they used a third-generation drug called lorlatinib, which is a more potent. And then primary endpoint is complete pathological response. And also look at that, they enroll only unresectable stage 3. Now, this is a very ambitious study. In a sense, is that you've got a unresectable stage 3 patient, ALK-positive. It's hard to find. You can only do this study in China when they have hundreds of patients to choose from. Now, I won't go through the detail, but just know that stage 3 is advanced stage, advanced localized stage. And a lot of these patients are N3, meaning that contralateral lymph node. About 55% of patients are contralateral lymph node. The stage 3, actually 11% of them is stage 3C, and actually stage 3A is about 37%, and 3B is 51%. And interestingly, this is their outcome. So number one, they were able to downstage the patient from N3 to N1 or N2. So you can see the percentage of patients who are able to get into the entry to the surgical resectable stage is 75%. So in other words, the conversion rate from unresectable to resectable is 75%, which is quite impressive. And they do that by downstaging from N2 to N0 or N3 to N0. And that is actually quite a significant achievement in terms of downstaging. But more impressive is actually the median pathological outcome. They actually report the complete pathological response in 47% and major pathological response at 81%. Now, this is the first time with the target therapy just come out 2 weeks ago that we were able to achieve such a significant pathological response. So I think although it's a small study, it's a very impactful study from China and from Guangzhou specifically. And then I'm going to just pick this one. And also apart from that, the logical study will also cover other uncommon mutations, which we don't have the data at this moment. So let me summarize. I think for driver oncogene is quite clear cut. The objective is to achieve a complete viral response, and hopefully that will improve event-free survival and overall survival. And now we have sufficient study from 816 demonstrating a 5-year benefit of about 10%. We were able to downstage the patient with stage 2 and 3, but then mostly it's a patient less than 1% PL1 benefit, and the role of adjuvant therapy, chemo-IO, is still debatable. For driver oncogene, neoadjuvant osimertinib is questionable, but it was able to downstage the patient, but no significant impact on complete pathological response. But then for neoadjuvant niraparib, I think it's associated with complete pathological response rate of 47% and major pathological response rate of 81%. So I think we have already defined with oncogene what we should do the neoadjuvant study. And for that, I thank you for the invitation, and I hope you enjoy your food in Shenzhen today. Thank you so much for your time. Thank you.